very warm welcome from the European Society of Cardiology Heart House in Sophia Antipolis, France. And we're starting this webinar on three-dimensional echo, state-of-the-art imaging, together with two internationally renowned experts in the field, which is on my left-hand side, Mark Monaghan from King's College in London, on the right-hand side, Pepe Zamorano from Madrid. My name is Ralf Stefan von Bardeleben. This webinar is sponsored by an educational grant of Philips Healthcare. To introduce the program and the faculty, the first speaker will be Pepe Zamorano, who will speak about 3D echo in automated LV quantification. We'll then continue with Mark Monaghan, who will speak about 3D imaging in valvular heart disease. And I will conclude with 3D echo fusion for interventions. This is an interactive webinar, and we will receive questions. We already received 21 questions from you as an audience, and we'll interactively integrate them into the program. All questions that will not be addressed during this webinar in a live session will be answered by email response during the next days. So we will start with Pepe now, who is giving his talk.
Thank you, Stefan. I'm delighted to be with you and with all of you via remotely. So now let me just share with you what is going to happen in the what's happening today in quantification with echocardiography. I think that there is no doubt that if we look to the guidelines, what is really accepted today is that 3D plays a clear, important role in quantification of systolic volume, diastolic volume, what happens in the chambers, and systolic function. In fact, we know that 2D is currently adopted in all labs, but it's not really the optimal way to assess LV function. And why is this? Well, we know that 2D has many limitations. It's subjective. You need really experience to interpret the images, and there is a clear lack of standardization when we use the eyeball. Well, in fact, there are also some assumptions that we need to know that are clear limitations for the 2D technology. The foreshortening, the geometric dependency, and also the tracing errors led to some important errors in quantification, what we want to know from the LV or from different chambers with 2D echo. And this is why the current guidelines really suggest to use 3D, but to know is not to do. And we know that 3D is superior, but is not used in many laboratories. So what is the ideal answer to this question? Well, the ideal method we know is 3D, but what we want is also to have an automated way of quantifying things while doing echocardiography. In fact, what we need is an accurate system, fast, easy to use, with minimal user interaction and reproducible. This means that, in my perspective, what we need is not acquiring the data. What we need is interpreting the data. So acquiring the data can be easily done by the technology, and the technology, what cannot do is simply interpret this data. So HUD model is the answer to that. Why? It really automatically corrects the foreshortening and also avoids geometric assumptions. And in fact, it's quite fast. It's easy to use and it's fast, as you can see in this short video that I'm using here just to show you how fast it works. It really performs the patient-specific adaptation of each left ventricle size. You can depict and you can correct the contour of the LV volume, and also you can slightly modify what automatically is done by the system. So then the question is, what is the correlation? Well, we know that the correlations are really, really strong. The ejection fraction in this paper was seen to be underestimated by using and calculating the ejection fraction, but also we need to know that when we estimate the end diastolic and the end systolic and the left atrium volumes were overestimated in this paper compared with the manual measurements. Also, it's quite important to know that it really saves time. And this is very important. Efficiency is getting very, very important in our labs, in our hospitals. So even if you correct or you adapt the model and you slightly modify what the system gives to you, you save time. Well, do we have a multi-center study in order to validate the heart model? We do have, and this is the paper that was published. We have participated in this study, 6 different centers, more than 150 patients. In fact, 180 patients were recruited for the study, and we're divided these patients into 4 groups according to the ejection fraction, estimated by 2D echo. And as you can see here, it's clear the inter-observer variability, and the correlation by using this heart model was very, very accurate. So in fact, in the majority of cases, we don't need to do nothing. The automated analysis is accurate. In some patients, we can manually correct the measurements that are given to us by the system, but this minor interaction with the system does not really improve significantly the correlation that is obtained without any interaction. So what happens if we don't select the patient? So do we have information in non-selected patients? And this is, again, a very nice study showing 300 consecutive patients that were admitted to the hospital, to the echo lab, just to do, for different reasons, an echo study. Well, in fact, here you can see that the correlation of the different variables with the heart model is excellent. And in fact, when we only analyze the patients without suboptimal acoustic window, the correlation is mostly perfect. So the next question will be, do we need an experienced echocardiographer, cardiologists, or technicians to obtain those data? Well, this is again the analysis of 100 patients that were analyzed without any 3D echo experience. So what happened in these cases? Well, in fact, you can see that the system is still very accurate. And in fact, you can see that in most of the patients, the system provides very accurate data with an extremely high correlation. And in patients that are selected, non-selected, optimal acoustic window, suboptimal acoustic window, or even if you don't have any excellent experience with 3D echo. Well, what happens in patients, and this is the recently paper published by the group of Tamborini, 200 consecutive patients, in fact, and they were just analyzing the correlation with the 2D biplane, the semi-automatic 3D full volume, and the cardiac magnetic resonance. And you can see that the correlation is quite nice in all the groups, excellent in the 3D group, as you can see here, but I think that the study from Tamborini clearly showed that there is feasible, easy to use, accurate, and in fact, the correlations with the 3D echo are almost perfect. Well, also, I think that it's very important if we use the adjustable slider position, if this really interferes or is related to the optimal result of the technology. And in fact, this is what we did in our study. We analyzed almost 70 patients with different conditions, and we adjust the settings to the different possibilities. And as you can see, even if there are some of the adjustments that are more optimal, but I think that the message here is that for all the measurements, it works pretty well with all the adjustments. It's true that some are better than the others, but I think that those minor corrections may improve your data, but it's only just to test you, to see how it works better for you, and I think that at the end of the day, all the different settings were properly well. Well, I want to conclude this short talk showing you how this really works in daily clinical practice. So I'm going to show you 2 cases where I do believe it's extremely important to be accurate. And you need to be accurate because after you take or analyze the measurements, you are going to take clinical decisions. And this is why imaging is important. It's not about taking nice pictures. It's about relevant information for the decision making. So let us analyze this first patient. A 77 years old male, previous smoker. I think that is also relevant to know that the patient had a previous ischemic heart disease, so it's a lot of gene information in stratifying this patient from the clinical perspective. And the patient showed a non-ischemic dilated cardiomyopathy with optimal medical treatment. The ejection fraction was 40%. LVVV in the ECG. And this means that we should, according to guidelines, clearly estimate what is the ejection fraction for the decision of CRT, for example, in such patients. Let us review the data. So you can see here the ejection fraction is 40%. No doubt that in this type of patients, we should not analyze the Takehome. I want to reinforce this message, and as it was clearly stated in the guidelines, and we have a dilated LV. So this is what happens when we use the automatic model, the heart model. We very fast and very accurately obtain the ejection fraction, and we can see with the different cutting planes the values that are obtained, ejection fraction, and the volumes. And in fact, those data were quite similar to the ones obtained by MRI. In fact, this is relevant. Why? Because we need this difficulty in these heart failure patients is the cutoff value of the ejection fraction, because with this cutoff value, then you may indicate CRT according to guidelines or not. So you really need to be accurate, and also it's extremely important for the follow-up of the patient, because it's not a single picture that we need from a patient. We need a video of the clinical history of the patient in order to take decisions. Also, this is true for valvular patients. We take decisions in the guidelines according to the volumes. We take decisions according to the ejection fraction. So we need to really be accurate here. Let me share with you this patient, 56 years old male with Barlow disease, mitral valve prolapse, severe mitral regurgitation, but remains asymptomatic. So here is crucial the data obtained by echocardiography, because severe MR in asymptomatic patients is not clear what to do. I mean, there are patients that are sent to surgery and they are coming with a prosthesis, which is a drama. It's absolutely different if they are coming with replacement or repair. So I think that sometimes you need to be careful when you take a surgical decision in an asymptomatic patient. So why heart model may help here? First, Takehome. I'm putting here the values just to really try to forget about Takehome's method by calculated ejection fraction. We need volumes. So the volume estimated ejection fraction was 70% in July 14, 68% in 15, and what happened in 6 months when the patient asymptomatic came for a follow-up visit. This is the echo from January to 15, so just to compare January to July. So the question here, will you be happy to take a decision with your eye here? I think it's quite tricky. I think that what really matters here is to have the same information, same accurate information during the follow-up of this patient. So what happened? So here we have 70%, 68% is really different, or is a different method that we are doing with a different hand. And in July, 58%. So what is the message here? The message is that we should estimate with the same methodology the values of the left ventricle, ejection fraction and volumes, with the lowest inter-observer and intra-observer variability. And what is the answer to that? I think the answer to that is the automatic quantification of the hemodynamics of the left ventricle. And this is what we have with heart model. We have the volumes, the ejection fraction that nicely can be obtained very fast and very accurate. And I'm pretty sure that the inter or the intra-observer variability between an echocardiographer or technician versus a machine is much better for the machine. You just need to interpret this data. So what is my conclusion? I think that heart model is a fast, easy, and reproducible tool that we should use in daily clinical routine in order to be exactly accurate and have less inter and intra-observer variability. Quantification, no doubt, is a must. We have in the guidelines, and we need to quantify to make clinical decisions. It's clearly the heart model allows a fast, easy, automatic, and reproducible quantitation of the left ventricle hemodynamics and left atrial volumes. Also, those measurements are really accurate, comparable to those obtained with magnetic resonance or 3D echo, for example, and it really promises to facilitate the integration of transthoracic 3D echo in the daily clinical routine. Thank you.
Pepe, excellent overview over this quantification topic. And I just pre-selected, we got so far 26 questions, and I pre-selected 4 of them, and I will give you 2 questions at a time for time reasons. So there was a question, what, Pepe, is a reasonable volume rate in left ventricular volumetric analysis, and how should the gain be set in 3-dimensional analysis? Should it be overgained, regularly gained, or undergained, the image? What would you say, Pepe?
Yeah, well, I think that the problem of volume rate is still, it will be always a problem. Why? Because once we are in a certain level, we want always more. Cardiologists, we want always more. So this is something, then the question is enough what we have today? I think it's enough. I mean, the data are there. Can be improved, for sure, will always be improved. And related to the gain, I think that the gain, we tend to overgain a little bit. What we never do is undergain. So from the practical perspective, I will go for try to overgain and then adjust, and not undergain, and then you are lost.
And there are 2 more questions. Which is for you the standard display if you don't use full volume analysis of the LV function and volumes? If you use Explain, what would be your standard views? And which are your limitations in a 3D full volumetric analysis of the left chamber?
Yeah, I think that we are lacking a standardization of 3D echo. This is a reality. But I think that Explain always help. It not only for the LV function and LV quantification. I think that it helps just to better obtain your image and better get the information. So Explain for me is always a must. And the second part was
the limitations of 3-dimensional full volumetric analysis of the chambers, so for volumes and ejection fraction. What are the limitations?
I think the main limitation is exactly the volume rate. I think this is something that we need to know, and it may vary from patient to patient, the needed volume rate, especially if we are dealing with valve diseases.
And there's the last question on the chamber quantification. What is, in your opinion, the role of contrast agents in 3-dimensional echo, and what would be the best 3D modality to use contrast in 3-dimensional echo?
Well, I'm not a fan of contrast in 3D echo, to be honest. I think that contrast is not really helping a lot in 3D echo. So it helps more in 2D. It helps more in 2D, and in 2D not only for border delineation, but also for volume estimation, and it helps. But it's not the same in 3D. We are not routinely using contrast in 3D echo.
Perfect. So we'd now like to go on, Mark, and I pass you the mouse for it. We're now going to the second topic, and you will introduce now the complementary role of 3D echo in valvular heart disease. Please.
Thank you, Stefan. But before I do, I'd just like to add a comment on and say that I couldn't agree with Pepe more about the gain issue, because you can't put data back into a data set. So if you undergain when you acquire it, that's lost data. Whereas you can always take it out again when you analyze it. So I think that's a really important point. It was a good question. Okay, so these are my disclosures, and I'm going to start off with a really historical slide, because this is a picture of the person who probably made the first echocardiogram, and it's difficult to imagine that it was over 60 years ago that Inge Egler first imaged and described ultrasound images of the mitral valve. And as you can see, these images here that we have are very, very different to the ones that we enjoy using today. And here's an example, and I'm sure Inge Egler would be really amazed to see these kind of pictures, which we almost take for granted now. which are 3D TE images of here a patient undergoing a mitral valve repair, and you can see this patient actually has endocarditis, so that's a vegetation here. And this is a patient with a mechanical mitral valve replacement, a bileaflet mitral valve replacement. And again, you can see with spectacular detail the surgical view of these mitral valves, and they're very, very different to the images that Inga Edler first started us off with. And of course, it's surgeons that we really need to communicate with, as well as interventional cardiologists. And this is a picture I took in our cardiac operating theatre, or one of our operating theatres, during a mitral valve repair. And here are two of our cardiac surgeons and the anaesthetist. And the information that we acquire from echocardiography is the information they need. And perhaps, you know, in years gone by, we might have presented them with an image like this, which is a transthoracic echo, and this particular patient, who you can see has got mitral regurgitation. But of course, we know that that's not sufficient for planning mitral valve repair, and so we would go with TE images. So I think perhaps I might just put the two of you on the spot just to check that you're concentrating. So we're going to go through these standard TE images here, starting off at 0 degrees, and we're going to tell the surgeon what the pathology is in this particular case. Pepe's putting his glasses on so I can tell he's concentrating. So obviously this patient has got mitral regurgitation. So here we are at 0 degrees in a mid-esophageal view, go around to about 25 degrees, and again you can see this regurgitant jet. So look at the leaflet pathology in some detail. We're around at about 100 degrees now, and again you can see the mitral regurgitant jet, and there we are at 113 degrees, and then finally we're around at about 145 degrees. Now, of course, you know, surgeons would really struggle to interpret those images and figure out what's going on. And because we're doing a live webinar, I'm not actually going to put the two of you on the spot. But this, of course, is what the surgeon wants to know. He wants to know what the pathology is. And as you can see in this surgical view of this very same patient, that actually there's prolapse here of A3. And this is a 3D TOE image, or TE image, I should say, in this very same patient. So here is the aorta and the surgical view above the mitral valve. And there you can see that prolapsing scallop of A3, which is almost identical to the real photograph. And as this rotates around there, you can see the regurgitant orifice. So obtaining an image like this is a great communication tool for the surgeon, because it really allows him to plan the operation and understand the pathology, and it makes it so much easier for us to communicate that to the surgeon. So that's one real big advantage of 3D TE. And of course, this has been explored in several studies, but this is one that was published in JACE just a few years ago, which compared that surgical inspection of mitral valve pathology during mitral valve repair to 3D echo, so 3D TE, to 2D TE, and to 3D transthoracic echo. And you can see here all the different types of valvular pathologies, the different scallops of the mitral valve that was involved. And you can see that in every single case, it was 3D TE in blue here that was more accurate than the other imaging modalities in terms of determining what exactly the mitral valve pathology was. So that's why this has now become our gold standard for assessment of the mitral valve. But of course, sometimes just a visual appreciation is not good enough, and we want to quantify. And there are tools available from a number of vendors now which allow us to do this in a semi-automated way. And this is one such tool which creates a geometric model of the mitral valve, in this case a Barlow's mitral valve, as you can see. And this generates from us in a semi-automatic way as well a number of measurements. Now, these aren't just important for mitral valve repair, but as you'll hear from Stefan, as we move into the arena of percutaneous interventions on the mitral valve, they become absolutely crucial in terms of knowing the size of the annulus, the angle, for example, between the mitral annulus and the aortic annulus, the tenting volume, tenting area, the length of the chordae. All those are crucial measurements for interventions, and they can be attained from 3D echo with tools like this. Okay, I think we've been doing enough talking now, so we're going to put you on the spot a little bit and ask you a question here, a multiple choice question. So in the 3D surgical view that I showed you just a few minutes ago of the mitral valve, I want you to tell me where you think the aorta is positioned. Answer number one, is it underneath the mitral valve? Is it on top of the mitral valve, to the left, to the right? Or don't we usually see it in that view anyway? Now, it's an easy question, so you have 30 seconds to answer. Stefan, though, let's...
Shall I answer it?
Well, I think you probably know the answer to this one. But, you know, I think a lot of times, actually, when people get that view, they they do some technical errors. They take a very, very big view of
Right.
it, and the frame rate is very low. And we were talking about that earlier on. Or else they zoom in too much on the valve, and then you don't get all the ancillary pathology, like, for example, the left atrial appendage, which confirms the orientation of the valve. So, you know, there are some technical issues in acquiring that view that I showed you. But do we have some answers from the audience now?
We already have the answer, and I think the audience is pretty good. We surpassed 35 questions, and we now have the answer to question number 1, and it looks pretty good. So 5% were answering that it's underneath the mitral valve. 70%, and I think that's already the majority, says it's on top at 12 o'clock, so which is true, so a very good audience. 9% were stating it on the left, 13% on the right, and 4% said it's not usually in that view anyhow, but I think 12 o'clock is a pretty good bet. We're 70% of our viewers.
Good. Well, it's a relief to know that most of them were paying attention when I pointed that out in the slide. So,
Absolutely.
now, as I said, in terms of making measurements, we have some tools that are available to us, and this is one such tool that is semi-automates the measurements of the aortic valve, and also it can be used for the mitral valve as well. And for example, when we're doing TAVI procedures, there are a number of measurements that we need to make of the aortic valve annulus and the height of the coronary ostia, and tools like this can automate it, just as we saw from Pepe, the automation in terms of the LV analysis. This makes aortic measurements a lot more reproducible as well, and are similar to the sort of tools that are available for CT analysis. In our center, we've used 3D-TE extensively for aortic annulus measurements during TAVI procedures, and these are our results just on this next slide here. And we published this a few years ago, and this is based upon nearly 300 patients in which we consecutively measured the annulus for TAVI procedures using 3D-TE. And as you can see, the incidence of paravalvular regurgitation was only just over 3%, which compares very favorably with any series that's been done with CT.
Absolutely.
So I think it just emphasizes the fact that it's not the imaging modality that matters so much, it's the expertise or what you're confident in using, and the fact that you must use a 3D imaging modality when you're looking at the valves, the ventricles as well. And that point is made by, we went back and actually looked what would have happened had we sized using 2D-TE, and in fact in nearly a quarter of cases we would have ended up with a smaller valve size and probably a lot more paravalvular regurgitation, and that's been borne out in other studies as well. Now, in terms of assessing aortic valve and mitral valve stenosis, as I'll explain in a minute, 3D is a very, very powerful tool. There's a number of different ways we can use it, but one of them is to use the fact that there are no geometric assumptions with 3D imaging, and that it means that we can get a view across the mitral valve using multiplane reconstruction to very accurately perimeter the valve area, whether it's the aortic valve or the mitral valve. And you can see what a difference that makes, because just as we move across the valve leaflets here, you can see that the difference in valve area goes from a critical valve area of 0.8 square centimeters to a valve area which would be compatible with more moderate aortic stenosis of 1.8, just by moving a few millimeters. Whereas if you do this with 3D echo and multiplane reconstruction, you can make sure you're right at the leaflet tips and get the true valve area. And as I said, this can be done with mitral valve disease as well, and here's an example of mitral stenosis. Now, this is not atypical. In this particular patient, this is where we could get the parasternal view. It's quite a low parasternal view, and you can see that it would be very difficult to get a true parasternal short axis view across the mitral valve leaflet tips. But because with 3D echo, we can do multiplane reconstruction, which doesn't make any geometric assumptions. We can correct for that. And in the interest of time, I'm going to advance through this, but what I'm actually going to do is take this blue box here and put that right across the mitral valve leaflet tips here. And so you can see, if I can grab this and just advance it here, you can see that in the bottom left-hand side here, we can obtain the mitral valve area and measure that very accurately. And that's been validated in a number of different studies. So I think I'm just going to skip on past that in the interest of time and talk about something which I think will be pertinent to your discussion in a minute, Stefan, and that's when we do interventions on the valves, we can end up with very, very complex flow lesions. And here's a patient who's had a mitral clip in here, and you can see that there are actually two regurgitant jets which merge together halfway through this procedure here. And quantifying that degree of mitral regurgitation can be very, very difficult. And 3D echo, there's no doubt it can help us in a number of different ways. And I think it's important because I really like this quote from Circulation, which said, if there's one valvular lesion for which qualitative severity is in the eye of the beholder, it's mitral regurgitation. And I think more than any other valve, this is the one where we look at it and we just say, hold a thumb up in the air and say, yes, it's severe or it's moderate, and we don't make the measurements that we ought to, and that's very important, particularly in this percutaneous arena. And so one of the ways in which we can do it is using these MPRs again and looking at the vena contracta. And as I've said, there can be multiple jets, so you can summate the different areas of the vena contracta. And whilst there's limited validation of this at the moment, it's probably better than trying to do this from 2D color images. And here's an example. So this is a patient who's previously had a mitral valve repair, and as you can see now has a leak around the annuloplasty ring here, which we want to quantify, and we went on to successfully plug this. But as you can see, we have a 3D color data set here. And again, in the interest of time, what I'm going to show you is that using MPRs on here, we could crop into this and then measure the vena contracta. So we've got the jet isolated here, and I'm lining up with it so that in the bottom left-hand side here, we can get the vena contracta, which you can just see there, and then we can trace the area of the vena contracta, which is better than just looking at the dimensions of it, because they're very rarely circular, these jets, and so this is a much more accurate way of doing it. An alternative method of doing this, which I think is particularly applicable when you've got multiple complex jets, and this is a technique that's been described by Pepe's lab, is to use a combination of 2D and 3D echo. So for example, in a patient with mitral regurgitation, we could calculate the stroke volume in the LV outflow tract using the conventional 2D methods. So pulse Doppler in the LV outflow tract to calculate the stroke distance, measure the diameter of the LV outflow tract from 2D echo, or the true area of it from 3D echo, and then we can get the stroke volume. And then we can compare that to the stroke volume obtained from a 3D assessment of the LV. And if you've got a patient with mitral regurgitation, then the difference between the two is going to be the regurgitant volume. So here's a 3D LV volume. Here is the stroke volume in the LV outflow tract from 2D echo, and the difference between the two in this particular case is 29 mils, which gives us a regurgitant fraction of 26%. And again, Pepe and others have described this and validated this technique. So I think, again, in the interest of time, because I want to leave some time for discussion, we'll just move on.
The questions are coming up.
Yeah, so. Okay, we'll just move on to the concluding part of my talk. And I want to show you some of the nice advances that are happening in 3D imaging of valve disease, but also other structures as well. And this is a high-definition photorealistic rendering of a 3D TE data set. And this is actually a mitral valve viewed on the left-hand side from the left atrium, so the surgical perspective, and on the right-hand side from the left ventricle in a patient who's got a perforation secondary to endocarditis. So you can see how this looks very, very realistic. But the other nice thing, as you'll see in a minute, is that we can change the light rendering on this. So we can move the light source around to actually look at it from a different perspective. And this is an example of looking at the aortic valve in a patient also with endocarditis, where the left coronary cusp has been effectively destroyed. And I'm rotating the data set round by keeping the lights and keeping the light source fixed. So you can see how the shadow changes on the valve, and you get a much better, a more realistic appreciation of the valve anatomy and pathology. And this is a mitral valve in a patient who's about to undergo a Cardioband procedure. And in this case, we really want to look in detail at the mitral valve annulus, as you only know too well, Stefan. And so this is the light source, which I'm going to move around the annulus. And you can see as I track it round, we can see in detail the structure and the anatomy of the mitral valve annulus and also the mitral valve leaflets here. And so the other thing that we can do with this is change the depth of it. So you saw me changing the position of the light source. So now what I'm going to do is change the depth of it, take it into the left ventricle. So now it's backlighting the mitral valve, which gives us an appreciation of the regurgitant orifice, but also the thickness of the valve leaflets, which I think could be quite important. And then this is a patient who's going to undergo a mitral clip procedure. That was the conventional 3D TE. Here is the photorealistic rendering of this valve, and again you can see the detail, the much more realistic appreciation. You can see how we can change the light source around to look at it in a bit more detail as we want to, and I'm taking it down towards the mitral valve just as I did in that previous example. And then what we can do in a second is turn this round now, so we're looking at it from the left ventricular perspective. So there's a regurgitant orifice, here's the LV outflow tract, and there is the regurgitant orifice that you can see there. And then this final example, if I can just move on here, is a patient who's undergoing a mitral clip procedure. And as you all know, that one of the crucial parts of this procedure is to make sure that the clip arms are perpendicular to the coaptation line of the mitral valve. And that can vary depending upon which part of the mitral valve you want to deploy the clip in. And sometimes that can be quite difficult to visualize. And so here we are looking at it with this photorealistic imaging, and what I'm doing is changing the light source round so you can see how the shadow of the clip is cast upon the mitral valve leaflets, and now I'm taking it through into the left ventricle so that we can see the coaptation line of the mitral valve backlit from behind. So just to conclude now, in terms of 3D echo evaluation for valvular heart disease, although I talked exclusively about 3D echo here, clearly it is a complementary technique to our standard 2D echo and Doppler data, and of course they form part of every investigation as well. But it does provide us with additional quantitative data on regurgitant lesions, as I've shown you, particularly in patients with complex flow patterns. And it can be semi-automated, just as it can be for the LV as well. It provides a more precise quantification of stenotic lesions because we can directly planimeter the true valve area, and as you're going to hear in a minute, is absolutely vital for planning percutaneous valve interventions, and is a great communication tool, not only in the cath lab between cardiac imaging specialists and interventional cardiologists, but also, as I showed you, in the operating theatre with our cardiac surgeons who actually have to operate on these valves. Thank you.
Congratulations, Mark, and I think Pippa and I could not more than agree that these were stunning images, and accordingly are the questions. So the first question is, and we should take them very short as a matter of time, how do you obtain such good quality in 3D TE? What's your secret weapon? What's your magic number? What do you do to get such nice images? There are a number of things. I mean, first of all, getting really familiar with your ultrasound system and making sure that you adjust the images precisely, keeping the frame rate as low as possible. Most of us do TE images now using a sheath on top of the probe to protect both the patient and the probe, and I think making sure you don't have any air bubbles in the end of that and compressing it is a very, very important thing because that can introduce artifacts. But I think, you know, working with someone and really understanding how you adjust the imaging on the machine is absolutely crucial. You showed very nice TOE images. Do you also use 3D for evaluation of heart valves in TTE is another question from the audience.
Absolutely. We use it all the time. 3D transthoracic echo is part of our standard protocol, not just for assessing the LV. We use it for assessing the LV in every patient using heart model as Pepe described, but also it's absolutely crucial for valve assessments. Every valve patient gets a full 3D transthoracic study as well.
There's another question. Is there a difference between the different brands and vendors, so between GE, Philips and Siemens in the quality of the images? But we of course only want to show strengths of the different vendors. What would be your main points? Software differences? I
won't go into specific differences between vendors, but I think what I would say is that all vendors have strengths and weaknesses. And certainly in our lab, we're a multi-vendor lab because we use certain machines for certain things and other machines for other things, because that means that we can serve all types of patients best of all.
Perfect. Okay, I would like to conclude now with part 3, which you already introduced by your talk, and which is the role of 3D echo in image fusion for interventions. These are my disclosures. As we've very well seen with your examples, and I was stunned by the A3 prolapse situation, we know that the mitral valve apparatus is a very complicated apparatus which is prone for three-dimensional depiction. And one of the nice settings that we show here in this little video on the right-hand side is that we're able actually to image the TE probe and to determine the orientation of the three-dimensional echo image into space and in the body of the patient. So we're able actually to put both informations from the fluoroarm in the hyperDOR and from the echo together. So one of the first applications to do this is actually what we see here, and this is just to depict the ring for a cardioband procedure, for instance, and to actually put it directly into the fluoroscopic screen. So we can see the perpendicular image planes, which is an LAO caudal in this image, but we could also change to get a perpendicular or a side view, which would be an RAO cranial, and this is immediately depicted with the correct three-dimensional echo overlay in this procedure. If we go more into detail, we see that actually echo is not so bad. So the annulus is a very complex landing area, complex landing zone. And here you see the comparison between the same patient in a CT and the same patient in a cut plane, MPR, as you pointed out, multiplanar reconstruction, to look into the different shellfish-like structures or different shapes of the ring structure to the leaflet. And of course, photorealistic imaging and the light sources tell us also about the thickness by putting the light below. And this gives us a very good impact on the situation where we can reach the ventricle and how long is the distance between the hinge point and any vessel, like the circumflex artery and the coronary sinus, which we'll also see later. So one of the first points in fusion guiding has been the mitral valve, has been transeptal puncture, and has also been MitraClip procedures. And this, for the first time, is actually where the echo specialist, the imaging specialist, puts the circle into the 3D image. And by putting the circle in the 3D image, you see here in fluoroscopy that the landing zone is defined for the interventionalists. So suddenly the world is turned upside down. And you see this was the first step, and this was back in 2015. There have been some iterations to even get this better. And one was, of course, that we need beating information. And here you can see the MitraClip banded down to the valve, correctly orientated. And you can see that in the fusion image live within the fluoroscopy and also the echo, and both images match, and you can see that nicely on the right-hand side of the TOE probe. One step further is to include, of course, color Doppler, to include hemodynamics into the image. And this is something we're lacking as interventionalists in the fluoroscopic image, because we only get pressure measurements. We also get, of course, some visualizations. We need a lot of contrast to do this. So to overlay not only the cardiac structure, but also the color Doppler is a huge gain, and also to define on which side we should place the next clip. And if we do it on the correct side, and this is just next clip, the regurgitation is gone, and you see nicely the result and the overlay on the right-hand side to control your procedure. The next step forward we've seen now in the last 12 months is actually to overlay not only a cut plane, which is with color Doppler, without, which is still two-dimensional echo coming from a three-dimensional probe, but to have a full volume data set overlaid into the fluoroscopy system. And you can nicely see that we see, like in your case with the prolapse, we see the distribution of a functional jet in this very sample, and you can see the extent in the different segments of the mitral valve. And this overlay is very exact, and it uncouples, as you can see here, the echocardiographer on the left-hand side who's looking on the sheath. On the right-hand side, you see the orientation that the interventionalist is imposing on the same dataset. And you nicely see also an echo, the ICD probe. And this is correctly overlaid. So you see two different informations out of the simultaneously same dataset, three-dimensional dataset. So we can look into depth, and we gain 3, 4, 5 centimeters of information for both sides. The next step is, of course, to enable grasping, and you see that you can switch within milliseconds between three-dimensional modes and two-dimensional modes, and that you can look at the clip here entering the left ventricle instantaneously, and can also see live the grasping process. Now the clip is put back, and you see this only takes seconds. Now the grippers are put down, and you can see that the clip is now closing, and you can envision this. And with the distance, which is more precise in fluoroscopy on the right-hand side, and again, this is done simultaneously. So the AP view is provided by echo, and the intercommissural view is provided both by echo and fluoroscopy in this image sample. So, but we can still move forward, and after the color, of course, we can also look for adjacent tissue. And in the past, this has been a stronghold for other imaging modalities like MRI or CT, like in this case, where we can depict not only the mitral annulus in yellow, but also the coronary sinus or the circumflex artery. And we can see the relation, the height, and the parallel distribution in this case. And if we extract this information into fluoroscopy, you can see here that we not only know the distance to the coronary arteries, but we know the height of the annulus, here given by an indirect annuloplasty with the Carilion system, but also a mitral clip. And this is a total transcatheter-based surgical solution. It's an annuloplasty and a leaflet edge-to-edge therapy, where we know in surgery this is more long-lasting than singular therapies, especially in dilated annulus. And we get very precise image information, and this is shown here. We have the left trigon, the right trigon. We have the end of the commissures here in the segment 1, A1 to P1, and here in segment 3. And we get all the different heights and points of the annulus and the location of the papillary muscles here in red. And they're all being superimposed throughout your procedure. And this is a video to show you this as a modern French correction. And you can nicely see that we have all these images. We use something like a touchpad. And again, for the matter of time, I put this a little bit forward. We see a three-dimensional heart in the fluoroscopy system. You now move the C-arm or the patient and you see that it turns and you get a perfect perpendicular view, side view in RAO on the mitral valve, which is always depicted. And with the yellow spots, I always know how it's orientated, and you can then treat by either going to the aorta, here given in yellow, or by the caval vein, you can go up to these structures. So this is very, very telling. And if you proceed with these procedures, you can do something like anchoring a cardioband, as you mentioned it, Mark, before, and here you see the anchors of a cardioband procedures. They're almost 1 meter long. And what we do is we get a three-dimensional image to steer this in a surgical or cardiology view, like in this case. We see the orientation of the devices to the heart model here that Pepe nicely showed for volume quantification. But here we use the heart model to directly do an intervention. So we steer it to the muscle. And this face here is the left ventricular muscle, and below is the chamber. And by doing this, we can intervene, and after some procedural steps. You see here the whole cardioband being deployed. You see multiplanar analysis live during the intervention. So not only 3D full volume, but all the cut planes that visualize the catheter, the orientation of the catheter to the mitral annular plane. Here 45 degrees, 50 degrees to the plane. And I think this is very telling to perform this procedure. And here's the result. And you can nicely see this is the native valve. This is the regurgitation before. This is the cardioband unchinged. This is the cardioband chinged. And this is the regurgitation after. And within 60 to 90 minutes, you come from this hemodynamic state to this hemodynamic state. And this is sometimes a reduction in LA pressure of 20 millimeters of mercury. So very, very traumatic. And we've shown this here in the European Heart Journal in October 2017. Another case is the replacement situation, which is upcoming next year. And in Europe, the first CE studies are now starting. Something that has been acknowledged by the guidelines is now to place a valve in valve, especially in the aortic position. And this has become from a no recommendation a 2A indication. And here you can see the injection of contrast and that the model exactly fills the left chamber. You see the atrium, the pulmonary veins, and the valve itself. So very, very nice overlay. But we can go on and see the contraction of the annulus. We can see the twisting and rotation of the annulus here with a stent of a tendine valve in place, a 3D echo image. But we can do the same nowadays with a full-blown multi-phase 10 images per second CT, as you can see here, where you see the contraction, the twist, and the transcatheter-based replacement in space. The next step to go is not to use CT, but echo to do all these analysis. So what we've seen nicely with Pepe on the chambers with TTE is done here with TOE to produce all the different chambers, left and right atrium, the ventricle here on the right-hand side. And this is now derived from echocardiography. You see the fossa ovalis here, the puncture point, and you see the mitral valve down here. So you can calculate whether your puncture site here is deep or high enough to reach exactly at 4 centimeters the mitral valve with your catheter. So you can pre-plan this for every procedure, what will be your result. And the next step forward is, of course, that we can do this with a contracting model, which is not possible nowadays with CT. So this is the next step forward, that we see atrial contraction in TOE and we see ventricular contraction on the next image, or the whole heart contracting during the procedure, and you can put in or put out different aspects of the heart while you're treating the heart. So this is true structural heart interventions or true valvular interventions for the future. And we now go on and see all these devices also with the nice photorealistic views that we've seen within your talk, Mark. And you see the occluder being placed after a procedure. You can see the mitral clip with the different light shadows that are very, very interesting if you change them in position, because you get a different aspect, and you can also differentiate shadows of the device from the probe position to actually shadows that derive from the catheter angulation. And this is a huge step forward in seeing this and deriving and seeing artifacts. And this was another question from the audience, whether we can use transthoracic imaging for mitral here and tricuspid leaflets that we see on the left-hand side, or the left atrial appendage that may be occluded in those patients as a bleeding risk. And you see it here before and after a Watchman implantation. So in the matter to discuss, we come to the take-home messages of this part 3, the fusion imaging. And I think we should all agree that 3D fusion echo may and will rapidly evolve in the next 3 years as a very innovative virtual surgical eye in intervention. So everything that a surgeon invests in his glasses or in a 3D Einstein videoscopic equipment will be done into virtual rendering of echo images in the future. Fusion imaging plays, in my opinion, an increasing role in hybrid OR settings with valvular heart disease, and you've also shown this, Mark. And the combination with CT and photorealistic imaging is another innovation step to improve native structural heart disease, SAD diagnoses, and the procedural control in interventions. And I think we can take now some questions together.
Yeah, those were spectacular images and a real insight into the future, I think, of where this is all going. And there are many more questions that we can possibly answer in the remaining 10 minutes of this webinar, but I've just got a few here. So, Stefan, first of all, a question which I think applies to regular 3D imaging, but also in the cath lab, patients who have arrhythmias, who are in atrial fibrillation, how does that affect 3D echo these days?
This is a wonderful change to the situation we had when we started matrix TOE probe imaging, especially in color Doppler, about 10 years ago. And I remembered I did my first images, I think, in 2007. And we had to render those images with 4 heartbeats or 7 heartbeats. So we were relying heavily on the sinus rhythm. Nowadays, all those images you've seen here in the interventions are single beat images. So actually in the mitral space, about 50 to 70% of the patients have atrial fibrillation. So ventricular extrasystole or atrial fibrillation is no contraindication and no quality indicator anymore with the modern matrix probe. So in the last 2 years, I think technology has advanced so far that we use about 95% single beat acquisitions, which are arrhythmia independent.
Yeah, and that's a really important step forward, I think.
Yeah.
Pepe, there's one here that I think you're best placed to answer, and obviously the audience was really impressed with your demonstration of the automated LV analysis, but the question here is there a software available for assessment of the LA and RA, and if so, what's its accuracy, and if not, can we implement the software that you showed for the LV to calculate atrial volumes?
Well, I think that the software is clearly validated for left ventricle, no doubt. The software is also validated, and we have some data from left atrium, and now is not really extremely validated for right ventricle. This is more tricky, but I think that this is coming, and there are some hints that we will use very, very soon the software for right ventricle. If I may add something related to the atrial fib, because this affects also your question. Well, atrial fib is not a problem for morphology. We have seen excellent, marvelous images from you both. But atrial fib really affects the interpretation of the volumes and the interpretation of the data, even the mitral regurgitation, because atrial fib affects mitral regurgitation from beat to beat. So you need to average, and you need to be clever enough to get all the data together.
So if you've got a patient with atrial fibrillation, I mean, how many beats do you think you should average LV volumes and even mitral regurgitation.
I'm far away of the common answer of 10 beats. I think that you should integrate the information. Sometimes you need 3 beats, see how is the rhythm. Atrial fib sometimes is quite rhythm, so it's well controlled. So it's different if you have an atrial fib that is well controlled or it's really changed beat to beat. So I'm far away of answering a specific number. It's just common sense that you need to integrate in your report.
Okay. And there's a question here which I'm probably best placed to answer about photorealistic imaging and how is it actually done. Well, actually, this isn't a technology that was invented for medical purposes. This actually is taken from the film industry. And there are a number of film companies, in particular Pixar Industries, which, as you probably know, if you've got children and grandchildren, they'll be wowed by Toy Story and all those films now, which you really use very, very clever reproduction of light sources. So they are able to calculate how photons will interact with different tissues and how they will reflect off those tissues and then interact with other structures. It's very complex calculations, but that's what they do in the film industry now for cartoons, and that's what's been applied to medical imaging. And it's not just 3D ultrasound. We can also apply this to CT, and that some spectacular images on the web if you look at CT imaging for this kind of thing as well. So there's another question here which actually I think is quite interesting, Stefan, and that is relating to 3D printing. So, can we 3D print from 3D echo data sets? And if so, what might we use that for?
There are 2 or 3 solutions. Actually, most 3D models so far are being printed from CT datasets, actually. But there is software around nowadays to use at least for valvular models, for leaflet models, etc. Also to use 3-dimensional echo to print, to do 3-dimensional printing. One of the hassles there still is, of course, the quality of the material, the different softness, etc., what to use to print actually these valves. But I think 3D printing is advancing a lot. What I see more for the procedures itself is holographic depiction of it. So I don't think really that we need to print every heart before we do a procedure, but I think we have to envision it more, and that we need different screens in the future. So I think we need more 3D screens, actually also in the cath lab, perhaps also in the echo lab, and we will need perhaps some sort of holographic display, so something like Star Wars, more or less in the future. What do you think?
Well, I mean, I think 3D printing is a useful technique, and we use it for some of our research. But on a routine clinical basis, at the moment at least, it's quite expensive. And I agree with you. I think holographic displays, but I think also computer simulation of interventions, so you can plan, and there is the software available for doing that at the moment. So you can plan precisely what's going to happen when you put that size valve in that position, and I think that will probably be the way forward.
I think this is upcoming, especially with the increasing demand for pre-planning in mitral valve replacement. I think the neo-LVOT and the LVOT obstruction is one of the big items, at least in the first 3 years of this technique. And to really predict this danger for the patient, which can be lethal to the patient, is something that will be covered also by software analysis tools.
Absolutely, I fully agree. And this cannot be solved by 3D printing because the heart is moving. The heart, this is different with the liver. So this is why I think that we are going to go in the direction of software and also holographic.
Okay, we've got one quick last question, and I'm going to put this to Pepe because he's so important in the ESC and EACVI. So there's a question here, do you think 3D fusion imaging, which I know you have experience with as well, is that going to be in the next ECHO guidelines and recommendations?
Well, I will not say yes or no, to be honest. I think that fusion imaging is going to be in the daily clinical routine. That is much more important than a document, because the importance of the document is the implementation of the document. So maybe that fusion imaging is going to be from not bottom up. This means from the daily clinical routine to the guideline.
Okay. All right, Stefan, let me hand back to you to tie this all together.
Okay, first of all, thanks you all for this excellent review of state-of-the-art imaging in 3-dimensional echo. And we heard 3 most important topics, which was 3-dimensional echo LV heart model. We heard about 3D echo in valve imaging and 3D echo fusion for interventions. And I think there are some certain take-home messages that we can put over to the audience. And the audience has been very active also with a number of questions, reaching more than 40 questions here. So I think anatomic recognition of the heart is advancing. And I think we have seen that there is precise imaging now, precise analysis also of the cardiac structures. So there's recognition, what is a ventricle, what is an atrium, what is an aortic valve, what is a mitral valve, and reproducible quantification. This reproducible analysis was something you pointed out nicely, actually, Pippa. I think there's also an added value in valve analysis, and not anymore like the guidelines in 2009 pointed it out in valve stenosis, but I think it has been recognized that valve regurgitation is actually a major part of three-dimensional analysis. And I also think we have shown that there is an added value in interventions. So to conclude it all, I think three-dimensional echo, state-of-the-art, is innovative. So we would like to close this webinar. And again, thank you very much for your participation, the excellent remarks, and the very nice and vivid discussion. Thank you.
It's been a pleasure.